Hello everybody, greetings from Istanbul, Turkey. I'm Dr. Rabia Merve Palalioglu. I will be pleased to present you an interesting clinical case today. COVID-19 in third trimester may not be as scary as you think. It can be innocent. Evaluating vertical transmission from a COVID-19 positive asymptomatic pregnant woman with early membrane rupture. Our article has been published in the Journal of Obstetrics and Gynecology Research. In the literature, many cases of COVID-19 positive pregnancies have been observed, mostly with mild findings, but there is limited evidence about perinatal transition and early COVID-19 positive newborns. In this case, SARS-CoV-2 reverse transcription PCR results were studied from samples obtained from the placenta, amniotic fluid, cord blood, and postoperative breast milk that were obtained while avoiding contamination and preserved appropriately of a cesarean section performed under anesthesia on a woman with previous cesarean section and gestational diabetes mellitus history. This patient, who presented to our emergency gynecology clinic with membrane rupture, was infected with SARS-CoV-2 2 weeks before delivery but was not treated as the disease was asymptomatic. In addition, literature data in line with this topic were evaluated to demonstrate that there was generally no perinatal transmission over 34 weeks of gestation. In this case report, we evaluate the potential of perinatal transmission from mother to fetus and safety of postpartum breastfeeding in a mother who had COVID-19 pneumonia and was diagnosed by computed tomography findings, despite a negative nasopharyngeal swab sample taken at the late stage of the disease. This study aimed to show that there is no perinatal SARS-CoV-2 transmission in the third trimester, especially over 34 weeks of gestation. On April 21, all members of a family with definite COVID-19 contact history and sharing the same house with a patient, husband had COVID-19 symptoms, presented to adult and child emergency clinics, and SARS-CoV-2 reverse transcription PCR samples were taken. The family was notified over phone that nasopharyngeal swab results were positive in all family members, wife, child, and the mother. But the results of the patient were not available at the time. During this time, the husband and mother with advancing symptoms received inpatient treatment for 5 and 12 days respectively. Patient anamnesis revealed that she had no symptoms since then, did not use mask in the same house with her child, did not follow isolation rules, and stayed in quarantine under these conditions. 14 days later, on May 4, she was admitted to our clinic with complaints of leaking vaginal fluid. The patient was 42 years old, gravida 2, parity 1, 37 weeks in vitro fertilization pregnant, had diet-regulated GDM, and had a previous cesarean section history. Preoperative nasopharyngeal swab was taken again from the patient without further complaints. Delivery was carried out by cesarean section under spinal anesthesia in accordance with all procedures and with protective equipment. A baby girl weighing 348 grams with 1 minute and 5 minute UPGAR score of 8 to 10 was delivered. Perioperative intra-abdominal acid was not monitored. RT-PCR samples were taken from the clear amniotic fluid, cord blood, and a placenta under appropriate conditions while avoiding contamination. You can see Figure 1. SARS-CoV-2 reverse transcription polymerase chain reaction was negative in the breast milk, cord blood, and amniotic fluid samples respectively. These samples were preserved at minus 20 centigrade degrees until the breast milk sample was obtained. After the breast milk sample was obtained from the patient, all the samples were delivered to the COVID-19 G-Lab Diagnostic Center of Health Institutes of Turkey. As the test results submitted 14 days ago were not available, a postoperative thoracic non-contrast computer tomography was performed until the second set of results became available, and diffuse peripheral and peribronchovascular ground glass appearance in nodular form was observed in both the lengths, and you can see in figure 2 chest CT scans of asymptomatic patients. The result was interpreted as a thoracic non-contrast CT with typical findings in terms of COVID-19 and was evaluated in favor of moderate to severe parenchymal involvement. Result of the first reverse transcriptase PCR sample could not be assessed due to a software error in the public health management system, and the second RT-PCR result performed 2 weeks later was negative. It was learned that during this 14-day period, the pregnant woman had contact with her COVID-19 positive untreated child without following isolation rules owing to lack of symptoms. Upon moderate to severe involvement in thoracic CT, the mother was isolated and the cefazolin, enoxaparin sodium, azithromycin, and hydroxychloroquine treatment was initiated. Swab sample was taken from the newborn and the mother, and the baby was given to the mother for breastfeeding while the mother was wearing a mask. The baby was admitted to the intensive care unit after developing feeding intolerance and vomiting 6 hours after being breastfed. Meanwhile, favipiravir was added to the treatment of the mother. No chronic disease, no risk factor other than gestational diabetes, asymptomatic, and had stable vital signs due to a sudden decrease in oxygen saturation level to 90 mm mercury on postoperative day 1 and monitoring of moderate to severe involvement in thoracic CT complaint with COVID-19 radiological findings. On postoperative day 3, oxygen saturation reached normal levels. SARS-CoV-2 nucleic acid tests that were studied using the nasopharyngeal swab sample taken twice from the mother and the baby during their hospitalization were negative. The baby was followed up for 1 week at the neonatal intensive care unit, and its general condition improved without starting any treatment. The baby and its mother were discharged 1 week after its birth. Pregnant women are susceptible to intracellular organisms such as viruses, especially respiratory pathogens, and those that cause severe infections due to changes in their cellular immunity. Maternal pneumonia is associated with various negative obstetric outcomes such as early membrane rupture, preterm action, intrauterine fetal distress, and neonatal death. In our case, wherein the procedures of sampling and delivery to the laboratory were fulfilled in accordance with World Health Organization guidance, it has shown that perinatal transmission did not occur at 37th gestational week in a mother who had asymptomatic COVID-19 and therefore was not treated. Another study reported that SARS-CoV-2 RT-PCR was negative in the amniotic fluid, cord blood, breast milk, and throat swab taken from 46 newborns born from COVID-19 positive mothers, confirming our case. In our case, negative RT-PCR results obtained from the nasopharyngeal swab taken twice from the baby, placenta, amniotic fluid, and breast milk suggested that there is no evidence of direct vertical transmission of SARS-CoV-2 infection in the third trimester. In our case, postpartum low saturation occurred with COVID-19 complaint, thoracic CT findings without prepartum symptoms related to SARS-CoV-2 infection. Lymphopenia is one of the common features of COVID-19 pneumonia, and some researchers believe that lymphopenia is closely related to the severity of the disease or mortality. Lymphopenia was not observed in our case on table 1. It is also known that in addition to SARS-CoV-2 infection, an increase in alanine aminotransferase or aspartate aminotransferase can be one of the clinical symptoms of many obstetric diseases in pregnant women. In our case, transaminases were within normal limits, suggesting that the increase in transaminase was not specific. Conversely, in a study published by Chen et al., thoracic CT showed findings of typical viral pneumonia, and the authors concluded that thoracic CT has a significant value in clinical diagnosis because of its high sensitivity and specificity. In suspected and confirmed cases, thoracic CT used to support diagnosis and determine the prevalence of infection, showing bilateral, peripherally localized ground glass opacities in the lung of patients developing COVID-19 pneumonia is typical. Diagnostic criteria of COVID-19 infection include 1. Typical thoracic CT imaging with more pronounced patchy opacities in peripheral zones of the lung, ground glass appearance, consolidation and infiltration. And 2. SARS-CoV-2 positive in RT-PCR tests. Negative tests results could be due to various factors in infected persons. Furthermore, studies showing that there may be a false negative RT-PCR results for COVID-19 infection cases due to low negative viral titer and improper sampling and swab sites in the late stage of the disease support the diagnosis in our case. The sensitivity and specificity rates of RT-PCR test that was used in Turkey is still unknown. In a study in which 114 patients were analyzed, while the PCR test made the diagnosis in 59% of cases, specific CT findings were positive in 88% of the cases. In a study conducted in Turkey, the sensitivity of CT for COVID-19 pneumonia is 97% shown. To date, there have been a few studies in the literature showing vertical transmission. In the first study, Zamanian et al. Demonstrated that swab samples taken from a newborn of COVID-19 positive 32-week mother were negative, but the amniotic fluid was positive for SARS-CoV-2 RT-PCR. This suggested that infants born under 34 weeks may have increased fetal exposure due to lack of surfactants. In the second study, no vertical transmission was detected in the third trimester. The other in a study conducted in Pope Giovanni XIII Hospital, Bergamo, Italy, one of the babies born from SARS-CoV-2 RT-PCR positive mothers was delivered by one normal and the other by cesarean delivery. It was reported that swabs taken from newborns were negative, but nasopharyngeal swabs results obtained after 7 days from both babies were positive. Although it is mentioned that there is no history of contact with their mothers for both babies, this suggests that adequate protective equipment and contact was not paid attention. The baby was asymptomatic and nasopharyngeal swab results were negative, suggesting that the fetus under 34 weeks acquired the disease through the intrauterine route. In a meta-analysis including 1,271 pregnant women infected with SARS-CoV-2 and almost half of whom were in the third trimester, no vertical transmission was reported to any infant. In our case, even the swabs were taken postoperatively. The elevation of interleukin-6 or C-reactive protein white blood cells, lymphocytes, neutrophils, and procalcitonin is noteworthy. Breastfeeding is not contraindicated according to several current guidelines published internationally. In a study, it was suggested that SARS-CoV-2 viral load was not detected in breast milk. Further benefits of breastfeeding were emphasized, and it was suggested that it should not be regarded as a means of transmission. In contrast, Chinese pediatricians recommended that babies born from COVID-19 positive mother should be fed by donor mothers or fed formula. In this case, we also show that there is no transmission from mother's breast milk. In our case, we only had late lung involvement due to the lack of early SARS-CoV-2 RT-PCR results in the period when COVID-19 lung involvement started due to the absence of immunoglobulin M, immunoglobulin G kit throughout Turkey. We were unable to prove that the patient with negative RT-PCR results had indeed had the disease due to the low sensitivity of SARS-CoV-2 to immunoglobulin M and immunoglobulin G. Even if we had obtained the kit, it could have only been used to support the diagnosis. Diagnosis could not be finalized in our case because of various reasons such as inadequate and inappropriate samples, obtaining the samples in the wrong period of infection, uncertainty over whether they were treated appropriately, the conditions during transport to the laboratory, and miscellaneous technical reasons related to the test. Thus, this case shows that CT is highly sensitive and specific in establishing the diagnosis of COVID-19. In the currently reported cases of COVID-19 and pregnancy, it was observed that cases with SARS-CoV-2 RT-PCR positivity were treated in the hospital during the third trimester after the symptoms started and delivery was performed, after the treatment was finalized. However, in our case, the patient showed no symptoms despite close contact with COVID-19 diagnosed family members, and therefore did not receive treatment because of the absence of results in the third trimester, and she developed postpartum symptoms 2 weeks after contact. In conclusion, the case presented in this report is one of the rare cases where cord blood, amniotic fluid, placenta, and breast milk samples were obtained and studied together. In our case, the infant had no clinical, radiological, hematological, or biochemical evidence of SARS-CoV-2, indicating that SARS-CoV-2 does not cause perinatal complications in the third trimester and especially after 34 weeks of gestation, and there is no vertical transmission. Further studies should be conducted in the first and second trimesters to find out possible perinatal transmission. Thank you so much.